So now it's my pleasure to welcome you to the session on dealing with lung diseases, lung issues. This afternoon's session will be presented by Dr. John Rudis. Dr. Rudis is a professor, chief of the Division of Asthma, Allergy, Immunology, and medical director of the Asthma, Allergy, Clinical Immunology at the Medical College of Wisconsin. And he is also a member of the IDF Medical Advisory Committee. And please join me in welcoming Dr. Rudis.
Okay, I tend to be a wanderer, so I'll get away from the podium when I can. Thank everyone for coming and hearing the talk. If there's something that's not clear during my there, an abbreviation, something, just interrupt me. It should be pretty informal. And then in the end, I'll take questions. If there are other issues, maybe a little more complicated that you wanted to discuss, I'm happy to talk as well after the discussion. So the lung is really the most common organ involved in virtually all PIDs. And really, even though my talk is predominantly focused on common variable and antibody deficiencies, what I say applies to all the others as well, combined immune deficiencies, etc. And I think that the thing that is the most important thing that we've learned in the last 5 or so years is it's really important to detect lung disease early and to make a diagnosis so that you can come up with the optimal treatment. And so what I'd like to do, and what we don't do very well as doctors, is just sort of go over first, what are the tools that we use to detect lung disease? How do we measure lung function? What does it mean? And then to go into some specifics, on lung disease in common variable. First thing that everyone has seen is the chest X-ray, right? And so everyone with any primary immune deficiency should have a chest X-ray. I mean, this is the initial screening test. And I say that, and people are probably saying, oh, what do you mean? Everyone doesn't get a chest X-ray. I mean, I had a 6-year-old girl with chronic granulomatous disease who was thought to have asthma, who presented at Children's Hospital with extensive pulmonary fibrosis. And it turned out, due to the CGD, just autoinflammation, but no one had bothered to get a chest X-ray. Had they gotten a chest X-ray, we could have picked up her pulmonary problem much earlier. And so it's just pointing out the main features of a chest X-ray. It's fast, it's cheap. It's a screen. It's not our best screen, but it helps. Now, the best screen for lung disease currently in primary immune deficiency are CT scans of the chest. And many of the things that I'm going to talk about, bronchiectasis and forms of interstitial lung disease, you can miss on a chest X-ray. And one of the great things about the CT scans of the chest now is, number one, the radiologists have figured out how to give reduced radiation doses when you get it. It's about a quarter to a third of what we used to get the same quality CT scans. And the second is the fine detail. And this is a normal CT of the chest, and the thing I wanted to point out are those 2 little holes there, actual airways. And those are normal airway size. They're about the same size as the structures near there are the vessels. And so you can see fine detail of the airways with a CT scan of the chest. So it's the best test to detect disease. Right now, it seems to be the best test to follow disease. But in the future, I think we may be able to use non-radioactive forms of imaging, like the MRI, to get similar detail. And studies are ongoing. There was one just published on MRI, and it looks really quite good. The bad part of MRI is just, tends to be expense. It's harder to do in younger kids just because you're in that for a longer period of time. And not all centers do MRIs of the chest, so there are drawbacks right now. So what are the, so we said chest X-ray, chest CT. Those tell us how the lung looks. We need something that tells us how the lung works. In other words, what's the physiology of the lung? And so pulmonary function tests are essential in the follow-up of patients over the long time with primary immune deficiencies. And so they should be performed periodically. We do it every year or every other year. We'll get full PFTs on our patients. And they're a great screen. The only drawback is whatever the charge is, and that's not much of a drawback. Spirometry is the simplest form of pulmonary function. And we get spirometry all the time, and I kick myself because we never sit down and talk to patients about what we're measuring. And so I thought it would be a good idea just to go over the baseline measurements and what we see when it becomes abnormal. So if you recall, when you do spirometry, you have the person take a big breath in, as big as they possibly can. Their lungs are completely full, and then you have them blow as fast and as hard and almost as long as they can. And I've done these. You feel like you're ready to pass out at the end of it. But the first thing that we get is what's called an FEV1. And that's the forced expiratory volume in 1 second. How much air can a person get out in 1 second? And then the other thing that we get is what's called the FVC, or forced vital capacity. And that's how much air you can get out total. Now, these values are normalized based on the race, the age, the sex, the height, the weight. And so we know pretty much what a normal value should be. Now, that's the simple screening test, spirometry. Now, the more extensive screening tests, which I think is important to do periodically, are what we call complete PFTs. And they not only measure the FEV1 and the FVC, but they measure lung volumes. Is the volume of the lung normal? Or is it contracted? Is it expanded? And importantly, they also measure the ability of the lung to extract oxygen. And so with all these measurements, with the CT scan and the PFTs, we have a great snapshot of what's going on at that particular time. In our clinic, in any new diagnosis of any primary immune deficiency, these are the screening tests that we initially get. We get a chest X-ray as the first screen, a CT scan of the chest, and complete PFTs. And then we have a baseline. We know, okay, now if anything changes, we know exactly what the baseline was. So there are two major types of lung disease. There's what's called obstructive lung disease, and this would be like asthma. Asthma is the most common obstructive lung disease. And in that disease, in asthma, the biggest problem is getting air out. And so they can't get air out fast. And so the really critical thing that's abnormal in asthma is the volume of air expired in 1 second, or FEV1. But eventually, if they blow long enough, they can get the air out. So the FEV1 is low, but the total volume of air expired is normal. And so that we have this ratio. How much air can you get out in 1 second versus how much air can you get out total? Normally that's about 80%, and it's lower in asthma. So asthma is an obstructive lung disease. Now, the other major form of lung disease is what's called restrictive lung disease. And this is when the lungs stiffen. They may become fibrotic, and they can't expand as much. So what happens is the person takes a big breath in, but he doesn't have as much volume, he or she doesn't have as much volume. And so both the volume that you blow out in 1 second and the total amount of air that you blow out is low. And so that is what's called a restrictive lung disease. In obstruction, you can't get the air out. Many times your lung is overinflated. In restriction, you may have fibrosis and it contracts the lung. So why the focus on antibody deficiencies? And again, I want to remind everyone that we'll be talking, what I tell you about antibody deficiencies will apply to other primary immune deficiencies, but really it's the most common immune deficiency that we see. So what are the common problems that we see in primary immune deficiencies? The first are pneumonias. And virtually, almost everyone that's had a serious primary immune deficiency will have had a pneumonia at one point in time. And they be, unlike a person with a completely normal immune system, they may be more complicated. And I'll talk about complications of pneumonia in a second so that you understand what I mean. But if I see a person in the hospital and they have a complicated pneumonia, I'm much more likely to look for immune deficiency than if they just have a run-of-the-mill pneumonia. So it'll also frequently take a longer period of time on antibiotics. And this is the thing that's hard for the community docs that maybe don't think about this a lot, is that the cause of the pneumonias in primary immune deficiencies are much broader. People that have problems with their immune system are also susceptible to unusual organisms as well as the same organisms that cause pneumonias in people with normal immune systems. So doctors must look for zebras in the lung when a person with an immune deficiency comes in and with pneumonia. So this is actually a true case, a 4-year-old that came in with a fever and shortness of breath, chest pain, and it turns out the brother had died of infection at age 3. And anytime you get a family history like that, you're like, something's going on here. It turned out that this child had what's called an empyema. This is one of the things that we call a complicated pneumonia. Normally, people don't get empyemas with a community-acquired pneumonia. They get lung inflammation. But this is actually pus between the lung and the chest wall. The bacteria is invaded through the lung, and now you can see there's areas of pus between the lung and the chest wall. And this child was subsequently diagnosed with X-linked agammaglobulinemia. So this is the most common inherited form of antibody deficiency. And, these patients, as you know, have virtually no antibodies at all. And it's a mutation in a gene called BTK, and it's the most common inherited form of agammaglobulinemia. What are other complicated pneumonias? Another complicated pneumonia would be a lung abscess. Normally, we don't see lung abscesses in a regular pneumonia, and an abscess is a walled-off collection of pus within the lung. So now that we've gone over the screens and some terminology, I'd like to talk just briefly about, or talk in more detail about common variable, or CVID. And sometimes there seems to be confusion about what it is. What is the diagnosis of CVID? And there are pretty strict diagnostic criteria that we agree on. And you should have a really, really low IgG and either a low IgA or a low IgM. And the IgA is almost always low or not detectable. And when we immunize patients with CVID, they don't respond. In other words, when we check for antibodies to what we immunize with, we don't detect them. And the age is variable. Now, in the United States, the second decade of life is the most common, but there was a recent European study that showed that 35% of their patients were actually younger than 10, which is surprising. And I think the incidence is much higher than 1 in 30,000. When I came to medical college not quite 9 years ago, and we actively manage over 150 patients with CVID now. And so it's out there. People aren't looking for it. And so we need to make the diagnosis earlier. So this is going to be an example of antibiotics in CVID. And this is a male that presented to the ER with just sort of a patchy little pneumonia. And when you read these chest x-rays, what you got to do is compare sides, and you can see this side's nice and clear or black, and there's just some sort of hazy whiteness there. And so what do you give? I mean, if you're going to give an antibiotic to a patient with CVID, you need to know the organisms that commonly cause pneumonia. And so it turns out that in CVID, yeah, they have pneumococcus, they get Haemophilus influenza, the so-called encapsulated organisms. But for some really weird reason, they're also susceptible to bacteria called Mycoplasma. And Mycoplasma are not covered by antibiotics like penicillin and sulfas and things like that. And furthermore, most labs don't even culture for Mycoplasma. And then finally, you can't draw an antibody test because the patient's on antibody, so you're measuring what's in the gamma globulin. And furthermore, even if they weren't on gamma globulin, they don't make antibodies, and that's why they have the disease to begin with. So in these cases, you actually have to empirically treat with an antibiotic that we know covers Mycoplasma. And this is probably the most common mistake that I see in patients with CVID who get treated for either sinus disease or pneumonias, is not thinking about Mycoplasma. And sometimes this is just a CT scan of the chest, and it's interesting, if you look at the chest x-ray, it doesn't look that bad, but boy, when you look at the CT scan of the chest, it's amazing how much pneumonia you pick up. And it illustrates, why the CT is so much better. So what about just chronic lung disease and common variable? And this is an old study that was published when I was at National Jewish. And, some people, if you catch them early, put them on gamma globulin, don't have any lung disease at all. But the two things I really want to focus on are bronchiectasis and interstitial lung disease. In both of those, as people are now screening common variable or patients with antibody deficiency earlier with CT scans, the percentage of interstitial lung disease and bronchiectasis has gone much, much higher. So this is another case of ours. It's a 24-year-old male with CVID who had normal PFTs. PFTs are a screen, and a completely normal chest x-ray. And here was the CT scan. It turned out this person had a form of interstitial lung disease. So bug your doctor. If you or your family member has not had a CT scan, they should get one, at least as a screen. And so we have published articles out there demonstrating that you can have normal PFTs and chest x-rays and very abnormal CT scans. So this is what we do in our center for all patients with primary immune deficiency. They all get a high-res CT of the chest, they get PFTs, and then depending on what we find, we institute therapy. They have one thing, we may give a higher dose of gamma globulin. If they have another thing, we may go to a biopsy. So what is bronchiectasis? Bronchiectasis is an abnormal dilatation of the bronchi due to repeated lung infections. Remember, bacteria, they cause white blood cells to accumulate in the airways, and those white blood cells are full of enzymes that kill bacteria. They not only kill bacteria, but they destroy tissue within the bronchi, and eventually the bronchi get widened, and the cilia that normally line those bronchi get disrupted. This can lead to chronic cough, and if those bronchi are abnormal, that part of the lung will be more susceptible to infection unless you are able to keep those secretions out. This is the most common pulmonary problem in primary immune deficiencies at all, period, and in CVID. Well, what do we know about bronchiectasis and CVID? You need to diagnose early. We know that if you have bronchiectasis and CVID, to remain infection-free, you're going to need a higher dose of gamma globulin than if you didn't. So if I get a CT scan on a patient and they have bronchiectasis and I've just made the diagnosis of CVID, I start them at a higher dose of gamma globulin because the studies have shown that you need a higher dose to keep them infection-free. It turns out, because there's chronic lung inflammation, that patients with bronchiectasis can turn over the antibody faster. We also institute measures that help the cough to be productive and to keep the secretions out of the damaged airway, and that's called pulmonary hygiene. And then in selected cases where it's severe bronchiectasis, we actually will give patients prophylactic antibiotics. So again, this is the normal CT scan with normal bronchi. And this is what they look like on a CT scan when they become abnormal. And you can see how huge those airways are in comparison to the normal airway that we just saw before. And this was actually a very sad case when I was at National Jewish of a young female who was diagnosed with quote-unquote asthma, but actually it had recurrent pneumonias. And bronchiectasis, like asthma, causes obstructive lung diseases, but her problem was common variable and bronchiectasis, and unfortunately, her lung disease was so bad that she died from her lung disease, this is a totally preventable complication of CVID. So, what about bronchiectasis? It's due to recurrent pneumonias. That's why if you're still having breakthrough pneumonias on gamma globulin, the dose needs to be increased. We treat patients, not levels, and so titrate the dose to prevent infection and prevent damage. Now, what about interstitial lung disease? And I want to say that I'm going to talk about interstitial lung disease in common variable, but recently, over the last 2 or 3 years, what's become apparent is the same interstitial lung disease that looks the same under the microscope can occur in other immune deficiencies apart from CVID. So if your doctor makes the diagnosis of interstitial lung disease and CVID, they need to think about these other immune deficiencies that can sort of masquerade like CVID. This is an older slide. It used to be said that it was 10 to 20%. There's a recent paper that says it's over 30% of patients with CVID have interstitial lung disease. And what does that mean, interstitial lung disease? That means that there's inflammation between the airway, the alveoli, which contain the oxygen, and the capillaries. Okay, the capillaries are what take the oxygen away and feed the organs. Inflammation between that and that space is usually very tiny, and it widens the space so that your lung can no longer extract oxygen efficiently. Now, there are a whole bunch of causes of interstitial lung disease, in normal people and in common variable. So the key is to know what that cause is. So one of the things that I'll talk about is this thing called GLILD, granulomatous and lymphocytic interstitial lung disease, but it can be caused by infection, it can be caused by lymphomas, other interstitial lung disease. So at our center, when we see someone that has a primary immune deficiency and they have diffuse lung disease, we get a lung biopsy. And when we get a lung biopsy, we do it with a scope, with a surgeon that's very experienced, and we sample at least 3 parts of the lung so that we make sure that we don't have an error just because of a sampling bias. And this is consistent with the recommendations by the American Thoracic Society. So you can be, I won't show it, but you can get fooled by doing the bronchoscopy and getting a piece of tissue because it's a smaller piece of tissue and it's only at a very small area. And there have been a few of my patients that have come from pulmonary who have had a misdiagnosis because they got a transbronchial biopsy. And this is what it looks like. You can see on a normal CT scan, the black means it's air, so the radiation goes through air more than if there was something there. And you see these alveoli in very fine structures. Now, in GLILD, those alveoli, the thing between the capillary and the gas, is expanded with inflammatory cells. And when they're expanded with inflammatory cells, the lungs cannot extract oxygen efficiently. So you need to treat this somehow. So what do we know, or at least I think we know? We need a lot more research on this. But at least in our hands, if a patient has what's called granulomatous and lymphocytic interstitial lung disease, in our experience, it doesn't respond to prednisone. Frequently, patients will be put on prednisone and they'll have all the side effects of steroids. They'll gain weight, their bones will get soft, everything else, and it doesn't really get rid of the lung disease. Furthermore, we use the lung biopsy and ask what kind of inflammatory cells are there to help us guide therapy. And we need more research to try to figure out exactly what causes this and how to most effectively treat it. Now, about 1.5 years ago, we reported a small series of patients in which we used what's called a combination of medications to treat this lung disease called GLILD. We used what's called rituximab, which gets rid of B cells. And everyone would say, why would you want to get rid of B cells? They make antibody. Well, these patients don't make antibody, and their B cells don't work. So getting rid of B cells, if they're a cause of the problem, is good. And then we use another medication called azathioprine. And the response has been pretty dramatic in these patients. I think it's great when you don't have to be a radiologist to see the before and after. It really clears out the lung disease, and once we stop the medicines, it seems like patients can stay in remission for a fairly long period of time. Now, whether or not they'll require retreatment, we've seen a couple patients that have needed to be retreated, but they've responded just fine. The other thing that's weird about the GLILD is they get big spleens and big livers. And you can see that red arrow on my right. That is a spleen, and normally in a normal person you can't feel a spleen on a physical examination. It's right under the left here. And in this particular case, the spleen went all the way, from her rib cage here down into the pelvis and was all the way to the pubic bone. And she was having difficulty just eating because the spleen was so huge. It was, you can see the stomach there sort of being mushed up. And the liver was massive as well, and you can see after treatment, the spleen size went down to about normal. And she's actually doing great. I just wanted to put up one slide to illustrate why it's so important to get an open lung biopsy. And this was a female that I saw with CVID. We looked at the CT and we said, I bet it's probably GL-ILD, but we should be sure. And someone else had gotten a transbronchial biopsy and there was no diagnosis. And it turned out this was a lymphoma. It was a low-grade lymphoma, but we treated it differently than we treated the GL-ILD, and she's actually doing great. And all we had to do was give a single drug, rituximab, which got rid of the B cells, and there were only B cells in the lung in this case. So you can see the before and after, and she's been in remission since then. So what I'd like to do is just summarize and then take questions. The lung's the most common organ that's affected in immune deficiency. The initial evaluation should include a chest x-ray, a CT scan of the chest, and what we call complete PFTs. Remember, those are the ones that measure the lung volumes and the ability of the lung to extract oxygen. Periodic monitoring then should be done to detect silent disease, silent lung disease. And that means, you know, we have two lungs. When we do lung transplants in people, frequently we just give one lung. You don't need two lungs. You can be perfectly happy on one. And because we have so much pulmonary reserve, patients frequently don't notice the lung disease or have symptoms due to it until it's more advanced. Pneumonias can be caused by usual and unusual microorganisms. Some primary immune deficiencies have unique lung diseases, and you should make sure your doctor's familiar with the lung problems that occur in primary immune deficiency, or advocate for you or your child and have them be seen by someone that is more experienced in this. And then I'm going to stop and take questions.